Hi, everyone. All right, so today I have the privilege of introducing Dr. Cassie Hajek as the first lecturer in Dr. Larson's new series of Grand Rounds lectures called the Sanford Scholar Series. Exciting things happening in internal medicine and good things to come. So Dr. Hajek got her undergraduate and master's degrees in engineering, industrial engineering at University of Michigan, Ann Arbor. And then she came to medical school here at USD and eventually completed an internal medicine residency in New York at Albert Einstein College of Medicine. Excuse me, at the off-sites, you might want to, if you're listening in, you might want to mute. I'll have to check with Jake to see who that is. Audience members at off-site locations, please mute. Thank you. We can unmute later if we have any questions. So, back in the flow, Dr. Hajek, homegrown, med school at USD, and then off to residency in New York, Albert Einstein. And then after building a busy primary care practice, you pursued additional fellowship training in medical genetics at UCLA. So, Dr. Hajek is now board certified in both internal medicine and medical genetics, and she leads the Imaginetics Initiative. I'll check with Jake to clean this up. Excuse me, at the off-site locations, can you please mute? Thank you. So as leader of the Imaginetics Initiative here, Dr. Hajek is delivering clinically actionable genetic information to patients in our primary care and specialty practices across the entire upper Midwest. Today you're going to teach us about polygenic risk scores for breast cancer screening. We're really super excited that you agreed to do this. Thank you.
So thanks, Dr. Wilkie. Thanks, Dr. Larson, for inviting me to speak today. I'm excited to talk about polygenic risk scores for breast cancer and coming to answer the question of are we there yet? And I have spent a lot of time working with polygenic risk scores for various common diseases, but breast cancer is a timely one for us, not only because we're working on that in some of the work we're doing in Imaginetics, but at the time I was asked to do this, I found a case in the Annals of Internal Medicine about the role of polygenic risk scores in breast cancer risk assessment. And I get really excited when I see genomic topics in the Annals of Internal Medicine. It makes me feel like genomics we're here, like this has infiltrated the mainstream medical literature. So that kind of triggered me to kind of dive into this for you today. So I'm just going to touch upon kind of where we are with current screening guidelines, and then I'll go into the genomics of breast cancer, risk SNPs, and polygenic risk scores for breast cancer, and then how might we apply these clinically. So as you are all well aware, we have recommendations from the USPSTF related to when we should screen women for breast cancer. Screening is recommended by their recommendations for women between the ages of 50 to 74, but then it's a shared decision-making conversation for ages outside of that range. I wasn't aware of this until I prepared this talk, that this topic is actually being updated, so it'll be interesting to see what comes of that. The American Cancer Society has a similar recommendation, but then comes those women who are at high risk. And figuring out who is at high risk is one of the questions that hopefully at some point in the future we'll be able to answer more with genomics than just clinical risk factors. But today we use clinical risk factors, as you're well aware, in various risk calculations. So these are things like the Gale model, the Tyrer-Cuzick model, Bodicea is one, and I'll talk more about that. These are risk models that, if you've used them, they're essentially a calculator online where you enter various inputs, including age of first pregnancy, family history of breast cancer, whether or not in some of these there is a BRCA1 or 2 mutation in the family. And the output ends up being the lifetime risk for breast cancer. And typically we use a cutoff of a lifetime risk of greater than 20% as a woman being high risk. And for those women, then enhanced screening, typically using breast MRI along with mammogram is recommended. This can be challenging because not all insurers are willing to pay for that, although more and more we see that happening. However, there is probably more that we can do here. And so that's where kind of the genetics of breast cancer comes into play. So we know that the risk for breast cancer doubles in women with a first-degree family member with breast cancer. About 20% of familial risk is due to those highly penetrant genes, BRCA1 and 2, PALB2, ATM, CHEK2, which are more on the moderate side of things. But then there's still a portion of heritability that exists that contributes to an individual's given risks. And that's where polygenic risk comes into play. And we get to those by using single nucleotide polymorphisms, or SNPs. So just briefly, as I'm sure most of you are aware, a single nucleotide polymorphism represents a single nucleotide difference. If more than 1% of a nucleotide at a specific position can vary, then that's considered a SNP. This is the most common type of genetic variation, and they occur normally throughout the genome. Individually, a SNP confers minimal risk, and these are what that risk has been associated and understood more through genome-wide association studies, which I'll touch upon in a minute. But to kind of put this in the context of genetic variation, if you think about like BRCA1 and 2, for example, these are monogenic disorders, right? And so they are very rare in the population, but the effect size is very large. And so that's where you would place Mendelian disease. On the other end of the spectrum, these SNPs are frequent in the population, but the effect size is minimal. And this is where we can start to understand and quantify the heritability of common disease. So that's where GWAS come into play. So a GWAS is a genome-wide association study, which allows one to look across the genome with a single platform, genotyping typically more than over 1 million SNPs at a given time, at a very, very affordable cost. This is typically done in a research setting to conduct GWAS or genome-wide association studies. So the way a GWAS works, and this is a great, actually, primer paper by Terry Manolio. But basically what it is a case control study where you take a set of cases for a given condition, say breast cancer, genotype that entire cohort, and genotype a cohort of normal individuals without disease, and then compare where there are SNPs with greater prevalence. Then you'll end up with this, what's called a Manhattan plot, and you'll see that there are SNPs that rise to the GWAS level of significance, which is 5 times 10 to the -8, a fairly stringent threshold. And those are good kind of candidates to look into further. Those SNPs are then taken into replication studies, into meta-analysis to look for validation of that association with the common disease or condition that is being tested. So for breast cancer, there have been many GWAS conducted. First was in 2007, but this is actually a really nice summary paper that shows kind of all of the different SNPs across the genome. So as you can see, you have your chromosomes here, and each dot represents a SNP across the genome that has been associated with cancer. So it's several hundred at this point. The color represents the effect size, and as you can see, most are black or blue. So the effect size of these, again, is small, as mentioned before. But for a given individual, if you end up having multiple of these, that effect size can actually turn out to be fairly large, and so that's what we'll talk about here in a little bit. The other thing that's important to know about disease association SNPs is that many of them are in the intron, and so typically in a regulatory part of the genome and not an area that you would find through kind of typical sequencing using NGS. So that's why these genotype platforms are important. So why is this important? Why do we want to find these associations for SNPs and associations for common disease? Again, going back to the idea that there's heritability that exists that we haven't been able to quantify to this point, but we are now. So a couple things that can happen with this. One, if you identify SNPs, it actually is very helpful in getting towards better understanding mechanisms for disease, and then obviously drug targets potentially. But also, if we can identify these SNPs, we can identify those in an individual and then potentially identify risk and ultimately identify screening and prevention approaches. So then that's where the polygenic risk score comes into play. So, of course, one SNP is of minimal consequence, right? Even 5 SNPs is of minimal consequence. But in a given individual, if you add up all of the SNPs associated with a common disease, say breast cancer, for example, you'll get a distribution for those who have many of the risk SNPs versus those who have just a few. And then what you can do, and there's different ways to do this, you can do either a weighted polygenic risk score or an unweighted, but through GWAS association studies, usually an odds ratio or a beta is determined, and that's the effect size of the given SNP. And so then you multiply the dosage at a given SNP by the odds ratio or beta, and then sum that across all of the risk SNPs, and then you have the polygenic risk score. So this has been done in many, many different disease states. So breast cancer, colon cancer, prostate cancer, coronary artery disease is one where there's a ton of evidence right now, atrial fibrillation. If there's been a GWAS and a disease SNP association study done to the extent that there are a significant number of SNPs, there's probably a polygenic risk score that's been tested out there. What's been even kind of more exciting in this field is that now we have larger and larger populations of genotyped individual, due in part to things like the UK Biobank, where you'll have hundreds of thousands of individuals who are genotyped, and then also have, most importantly, the clinical data associated with that, so you can do these association studies and get to the power needed to identify these associations. So for breast cancer, it's no exception. There have been several polygenic risk scores conducted since 2012, actually. I was actually kind of surprised to see that. And so over the years, the number of SNPs has increased as discovery has increased. And the most recent one, this should say 313 SNPs. But, at the very early stages, even at that point, the number of SNPs was low, but you were still starting to see an association between risk and between breast cancer risk and polygenic risk score. What's interesting about these is that this area under the curve isn't terribly exciting, but what's really important is how the ends of the distributions actually perform, and that's where I think the value of the polygenic risk score is. So with this most recent polygenic risk score, that last one mentioned there, so this was just out in 2019, and then has been replicated, and I'll show you a couple different studies in which other populations have tested this. But basically, they took a development data set with over 94,000 cases and 75,000 controls, and then validated that in an additional 11,000 cases and 18,000 controls, plus another 190,000 women from UK Biobank in a prospective manner. And so what they were able to demonstrate was that, again, there's an association with increased risk for breast cancer and polygenic risk score. So on the Y, you have the odds ratio, and then the percentile of polygenic risk. So at the very lowest polygenic risk score, you've got a odds ratio of about just over 0.2, and then at the very highest, greater than 99th percentile of the polygenic risk score, you've got a little bit over a 4x odds ratio for risk for breast cancer. And then the way they were able to then apply this to assess for lifetime absolute risk was because they had this 190,000 women cohort. And so what you look at here is if you look at lifetime absolute risk, 20%, like I said before, is the cutoff for assessing someone who's at high risk. That actually correlates to a polygenic risk score somewhere between the 90th and 95th percentile. So if you think about clinically applying this, if you just thought about PRS alone and you calculated PRS for a breast PRS, you would probably say, okay, women in that percentile risk are those who you would refer for breast cancer enhanced screening. So far this study has had the highest discriminatory power to date, and it's been consistently associated with elevated breast cancer risk. This group took that polygenic risk score and compared and modeled this and compared using risk assessment based on family history alone, polygenic risk, the combination of polygenic risk, and then a risk-based constrained model, which is polygenic risk alone, but screening individuals based on their polygenic risk. So you change the actual frequency of screening based on the polygenic risk. Again, this is modeled. But what stands out is the family history and polygenic risk model, because you got the most life years gained, the most breast cancer deaths averted. There was some overdiagnosis and false positives, but your ratios to these to screens over diagnosis and false positive were the most favorable. So this starts to demonstrate that one screening component alone probably isn't enough, that moving towards using the combination of family history and polygenic risk is important, but also that polygenic risk is independent of family history, which is important when you're thinking about all the different things you consider in risk assessment. This is another group, a Dutch group, and actually we work really closely with this group out of the Rotterdam study. And so essentially what they did is in their population, and they have, I think they had over 11,000 cases controls combined. I don't have that number right in front of me here, but again, you can see that relationship is exactly what was demonstrated in the original study with that 313 variant polygenic risk score. So they basically replicated the power of that polygenic risk score, but again, what they did was they took the Bodicea model, which is another one of the risk models that we can use for breast cancer assessment. And if you haven't gone to that before, it's actually really quite interesting. You can just Google it, and the calculator will come up. And the way it works is that you enter various clinical risk factors, of course, but you also have the option of uploading a variant call file with genomic data and or put in a polygenic risk score so that it will incorporate that into the risk assessment as well. It still has a lot of validation to be done on it, but it's it's pretty exciting that actually exists today, that we can use it. But on these density plots, you start to see, so the first one is just age and clinical risk factors. The next one was just age and polygenic risk. And the third is age, risk factors, and polygenic risk score. And as you can see, as you move to the right and incorporate all of these different factors together, you start to better discriminate between the red, which is cases, and the blue, which are controls. And so it's really a good example of the fact that not one screening mechanism or risk calculation is going to be is going to perform as well as multiple together. Okay, so that's all very exciting. We can use polygenic risk to help discriminate those cases and controls and that kind of thing. But another application where we really have a need is in monogenic disease risk. So I'm sure you all have patients with breast cancer predisposition syndromes, and in some cases, you have a patient who has a BRCA1 mutation and she doesn't have breast cancer. And the question is always why, and the patients always want to know, why and how do I know this, and do we modify screening based upon fewer people in the family with this? The answer to that is no. We don't do any sort of modification for screening, at least today, based on family history alone. You might consider some changes, but as a general rule, you stick with kind of the protocol for these high-risk patients. But polygenic risk, if you apply it on top of a patient who has a monogenic disease risk like BRCA1 and 2, in this study what they showed was that carriers of monogenic disease risk actually in the lowest percentile polygenic risk actually had a lower odds ratio for breast cancer than those in the highest percentile for polygenic risk. So it really helps to better modify the risk for these patients we know to have monogenic disease. And so this was done in, again, UK Biobank, which has been a phenomenal resource for a lot of these studies. And they've done it for other monogenic conditions like Lynch and familial hypercholesterolemia. But this has a lot of promise for how we might better counsel and then do surveillance on patients with these conditions. So kind of the key findings with breast cancer polygenic risk score. They consistently associate with breast cancer risk. That's been demonstrated now for several years. The risk is independent of family history and classic risk factors. Like I mentioned early on, the strength of the association is greatest at the extremes. In breast cancer, the effect size tends to be larger for receptor positive, ER per receptor positive than negative, probably at this point because we just don't have the numbers of cases in some of these studies to be able to get there, and that's just going to take time. They appear to modify monogenic risk. A big challenge with polygenic risk scores, and one of the big limitations right now, is that much of the data has been derived from Caucasian patients. And the polygenic risk scores that have been derived from European ancestry data have generalized well to the Latinx ancestry, but less so to African ancestry. So there's still a lot of work to be done there. And these studies are ongoing. So we're hopeful that this kind of will be resolved soon. So because of all of this data and evidence that this could be a helpful contributor to risk stratification for patients with breast cancer, we decided we wanted to test that polygenic risk score, the most recent one, the 313 SNP score, in our patient population. So we have, through our preemptive genetic screening program and then through our research biobank, we have close to 40,000 individuals who are genotyped, and then through our research protocol, we can link that genotype data back to the electronic medical record, and so it allows us to test these polygenic risk scores in a pretty readily fashion. And so what we did was we pulled all of the patients' genotype from that population. We had 944 cases, 15,000 controls. And then we defined cases using ICD-10 codes from the EMR. And the ICD-10 codes, actually, we get benefit because of the eMERGE network, which is yet another great cohort, which essentially helps to define how we phenotype, basically using electronic health record data. And so it really gives us the ability to have a consistent definition for cases and controls across different studies. And so then we took the 313 SNP polygenic risk score calculated for each of the participants in our genotyped biobank and preemptive genetic screening population, and ran the association and survival analysis. So this is what the distribution looked like. The red is the cases, and blue is controls. And as you can see, the PRS is shifted to the right for the cases, so demonstrating a slightly higher polygenic risk score in the cases. And so when we assessed for the continuous PRS for all samples, we had a 1.5 odds ratio for each increase in standard deviation for all of the women studied. We did pull out samples that had monogenic disease just to make sure we weren't seeing some kind of a skewing effect there. There aren't that many, it's only like 22, but just to be safe. And we did not see that, and as you can see, the level of significance is very favorable. And so I think it's most interesting to look at this in a graphical depiction. So as you can see here, and the common way to do this is to compare to compare against the middle. So this association analysis compared to the bottom 50%, And so then you look at those with the, at the 50th percentile, what the odds ratio was, and then go up there. And so as you can see, it shows a very nice relationship between increasing polygenic risk score and odds ratio for breast cancer. And these are just the p-values at each of those different points, which were highly significant. We then did the association analysis, and this is where you compare to the middle 50% because you assume that that's the population level risk. And again, we saw a really nice curve, similar to what was published with the Matavet study, the first study that did this polygenic risk score. And as you can see, in the the lower 5% of individuals had an odds ratio less than 0.5, and once you kind of get to the highest percentile polygenic risk, you are getting close to 2.5 for an odds ratio, and all of these, again, were highly significant. We then did the survival analysis, and again, you can see that relationship really increasing nicely with increased polygenic risk score and increased hazard ratio, and a similar curve to what was demonstrated in the Matabat study. So, not surprising, because we have the same sort of ethnic demographic in our population as was studied in the original population, but important to ensure that what's been demonstrated in the literature does apply. This was just a reminder to show you kind of that curve again. So it's really hard when you're using electronic health data to be able to pull out who has been assessed as being high risk for breast cancer versus not. And so we use the proxy of individuals who were referred for screening breast MRI to say that these are women who have been deemed to be at high risk for breast cancer based on some risk factor. We didn't go into charts and pull that out. And so our numbers were quite small here. We only had about 97 individuals who had actually had an MRI among those that we studied. But what we did find was that the individuals who did get referred for a screening MRI, they did have a increased polygenic risk score on average than those who did not have a breast MRI. And so there are obviously lots of limitations here, one being that even if someone didn't have an MRI, it doesn't mean they weren't referred for one, they just didn't get it. And so, we just don't know some of those things because we're sort of limited by what we can pull from the data. But in any case, that modest difference between the polygenic risk scores for those who had the MRI and those who did not was significantly, statistically significant. So there's a difference. We just the numbers are so small. We then looked at are the people who had an MRI with a breast cancer diagnosis or the people who had MRI without a breast cancer diagnosis, does the PRS differ? And for the cases, it does not. So that's actually helpful. For the controls, it was not. It was different. And so again, those who are referred for the breast MRI had a higher polygenic risk score. The cases, it's not surprising that polygenic risk score should probably be the same among those referred. So we basically were able to replicate what's been demonstrated in the literature. We tried to assess it based upon level of risk as dictated in the clinical setting, with some pretty stringent limitations. We're working on ways to better identify women at high risk based on data that we can pull from the EMR, and so that's work yet to come. But taking all of this and knowing that we have this additional tool to incorporate into our clinical risk and age and all of the things that we do to identify women who could benefit from more enhanced surveillance, or I suppose at some point who may benefit from less frequent surveillance. And so you can think about the different clinical applications that polygenic risk could apply. So certainly for women at population risk, are there some people who don't necessarily need to be getting annual or biennial mammogram? For the women who have a family history or other clinical risk factors but no monogenic disease risk, how can we better quantify risk for them? Polygenic risk has potential there. And then, of course, as I showed you, what's been demonstrated as it relates to monogenic disease risk. And in all these cases, we really have the opportunity, as we move forward in this space, to better risk stratify and do better surveillance, identifying those who might benefit from more screening, but also those from less screening. So, in answer to my question from the beginning, are we ready? Well, we're not quite there yet. This is all, I think, very encouraging and exciting, but there's a lot that needs to happen yet. First of all, most importantly, validating polygenic risk in all ancestry groups. If we want to use it as a population study, we need to make sure that we have something to offer the entire population. There haven't been studies with outcomes yet to assess the clinical outcomes of PRS-based screening. However, they are underway. Two of them are the Wisdom study. Sanford is an enrolling site for Wisdom, and then my personal breast screening. Hopefully, within the next 2 years, we'll see results from those. But essentially, each of these is comparing age-based versus risk-based screening, including genetic markers and family history. As of now, there's no standardized approach to calculating polygenic risk scores. So as you can see, there is a long history of polygenic risk scores, and there's always new discovery. At some point, there needs to be some approach to say you have to include at least this number of minimal SNPs, and we have to have some sort of level playing field, because what happens today, and you may have encountered this in a clinical setting, you can get polygenic risk scores, patients can get them with direct-to-consumer testing. They could have 2 different scores, and what do you do with that? Nothing today. One way that we're going to try to sort of sort this out is to do a pilot using the polygenic risk score to identify women who could benefit from a high-risk breast clinic referral. So right now, doing these calculations using the IBIS or the Gale model requires a high level of suspicion and then a lot of interaction to get to that assessment, which is really important and needs to be done, although we probably aren't doing it in an equitable fashion. And so if you have genomic data for a broad set of patients, you can calculate the score and say, okay, above the 70th percentile, let's refer to high-risk breast so that they can get this assessment. And you'll miss fewer people than we're missing now. I kind of outlined our pilot approach for this that we're working on, but essentially it's that. And you would not use the breast PRS at this point to say a patient needs a breast MRI, but just to get them in for high-risk assessment. So it's at least a starting point. So I'm going to stop there. That's kind of breast cancer PRS in a nutshell. I think it's a really exciting space, and it's just one of the many applications for polygenic risk. And it's a fast-moving field, so I think more to come in probably as little as a couple years. And if you're wondering about the case in here, so what was presented was a woman who I think was 45 and had a few risk factors, and based on one of the clinical risk assessment tools, her risk was 26% for lifetime risk for breast cancer, and so she qualified for a referral to high-risk breast or for breast MRI. But the way they illustrated it in the case was that she was really aggressively pursuing a polygenic risk score, and so they did it, and it modified her risk to 16% lifetime risk, which wouldn't qualify her for a breast MRI. But I don't think there's anyone who would say, okay, never mind, you're no longer high risk just based on that alone. And that's kind of the takeaway from this, is that yes, we might get there, but we're not quite there yet. And I think most people would feel comfortable sort of up-screening using this tool, but down-screening becomes another conversation that I think we still need a lot more clinical data. So I will stop there and open it up for questions.
Kathy, thanks a lot. That was really authoritative and So they're on site. Do you want to invite the audience off-site? There are a lot of folks zooming in to unmute and ask questions.
Yeah,
See if you have
yes. Those that are on Zoom, please unmute and ask questions if you have them. And I can't see if they unmute. Okay. And if there are questions, just chime in and we'll field them.
While we just wait and see if anyone speaks up, I have a question. Can you show us that modified curve again? You showed it at the front and you showed it on there. You called it a reminder curve. Yeah.
Oh, well.
Yeah, your data kind of, even though you have a small sample size, it mirrors that shape.
Mm-hmm.
So here's my question. If it's way down on the left and it's way up on the right, does that mean you have a negative predictive value if they're being both score?
Yeah.
And a really good positive predictive value for a really, really high score, but the middle of the pack's not particularly helpful.
Right. So if in these curves, you're comparing to the middle 50%. So you would expect it to flatten out in the middle. But yeah, just as you said, it's the ends of the curves that are going to be the most discriminatory in these models, and that's exactly what that demonstrates.
That might be actionable. That might relax a little on the screen frequency, maybe
Yes.
on the left hand. You
Yes.
definitely lean into the screen frequency on the right.
Yes.
And then that case at the end, I was thinking about this, that you pointed out, we slid from 26% to 60%.
Yeah.
Right in. So in this case, she wasn't on the tail, the score was particularly.
Not very helpful. But and it's hard too because it was like in isolation. So these models need to be a combined model so that you don't have to try to figure that out in your own mind. Yeah.
So to do a prospective trial in this phase, it would seem to really get the most guess sample size. How big do these studies would have to be?
Well, so with the Madhavat study, a piece of that was kind of prospective, and that was 190,000 women. So these are big. And that's, unfortunately, we are starting to have big numbers of genotyped individuals where we can start to do this. I mean, these couple of studies are 69 studies, and that's how they got to even this just development data study set. But yeah, I mean, we'll see. I am not sure where Wisdom or My Breast Cancer Risk are for an enrollment. But I'm thinking they're approaching these numbers, and hopefully we'll have some good data from those.
So are all SNPs given equal weight in the calculation of the polygenic risk score? And another question kind of going with that. Do we know what really the gene products are for the SNP? I know you mentioned a lot of them.
Yeah. Yes. So the first question, are all SNPs given the same weight? It depends. The weighted scores take the weights that have been derived from the genome-wide association study. And so, you'll see studies most commonly with the weighted scores, and those tend to perform the best, although unweighted scores are out there. I think that's just starting to maybe be of lesser favor. And then do we know the target, where these point? So sometimes, not always. And it just sort of depends on the disease state. But that's obviously key to figuring out the mechanism component of this. everybody.